Assalamu alaikum. Welcome to this lecture on diseases of the ovaries and fallopian tubes. I'm Dr. Valérie Dubé. I'm a gynae pathologist at the University of Toronto. I would like to thank you for allowing me to the opportunity to teach to you. And again, I would like to apologize for not being able to teach to you in Arabic. So for this lecture, we will first do a brief overview of the anatomy and histology of the tubes and ovaries, and as well go briefly over some of the non-neoplastic tubo-ovarian lesions. And then we will delve into the bulk of the presentation, which is about ovarian tumors. Okay, so the histology and anatomies of the ovaries. So if you remember the lecture we had on the ovulatory cycles, you know that the ovaries contain multiple follicles at different stages of developments, and each follicle is composed of germ cells, which are the ovocyte, as well as sex cords, which are an inner layer of granulosa cells, as well as an outer layer of theca cells. In between the follicles, the ovary is made of a fibrous stroma that will support the structure of the ovary and contain the blood supply for the ovary. There also can be some epithelium present in the ovary. So first, there is the surface of the ovary is covered by a mixture of mesothelium, which is a special type of epithelium, as well as some tubal type ciliated serous cells on the surface of the ovary. Some tubal epithelium can also be found within the ovary because it can be entrapped during the process of ovulation. And then we can also find some ectopic type of epithelium, such as endometriosis within the ovary. The fallopian tubes, well, they are composed of an inner layer, which is the mucosa, which is surrounded by a muscularis layer composed of smooth muscle, and finally covered by a serosa, which is made of mesothelium. The fallopian tube is basically an anatomic bridge between the ovary and the uterus to allow the transfer of the fertilized egg. So the mucosa of the tube is made of multiple prominent folds, which role is to facilitate the transport of the ovum. And the mucosa is lined by serous type cells, which are ciliated, and the movement of these cilia will also allow for the movement of the fluid present in the tube to help with the transport of the egg. The fallopian tube is divided into anatomic section. There is the isthmus, the ampulla, the infundibulum, and finally the fimbriated end. The fimbriae plays a really crucial role in capturing the egg after the ovulation, and it's important to know about the fimbriae because it is the main site of malignant transformation into high-grade serous carcinoma, and we will discuss that later on in the lecture. Okay. So the fallopian tubes and ovaries can be the site of different types of non-neoplastic diseases. For example, fallopian tubes can develop hydrosalpinx, which is basically a dilatation of the tubes filled with fluid. They can have salpingitis, which is an inflammation or infection of the tube. There can be PIDs, pelvic inflammatory diseases. The ovaries can have endometriosis or endometriotic cysts, tubo-ovarian abscesses. They can undergo torsion and swelling. There can be different types of functional ovarian cysts, such as follicular cysts, corpus luteum cysts, and so on. So I will not delve into the details of these benign diseases, but what is important to know is that while these diseases are non-neoplastic, they can still significantly affect the patient's quality of life. Because they can give chronic abdominal pain, they can affect fertility. Patients can present with an acute abdomen, for example, if there's a torsion, a rupture of a cyst. And very importantly, also, is that these diseases can also be mistaken clinically and radiologically for a neoplasm. So you can see on the picture here that is a tubo-ovarian abscess. So you can see how it presents as a large, solid, and cystic mass of the adnexa, and radiologically it can be mistaken for a tumor. Okay, so now let's talk about the bulk of the presentation, which is ovarian tumors. So ovarian tumors are characterized according to the structure from which they arise. So we said that we can find different types of epithelium in the ovary, and that can lead to epithelial tumors. The germ cells within the follicle can lead to germ cell tumor. The sex cords that surround the follicle, as well as the stroma in between the follicle, can give rise to sex cord stromal tumors. And finally, the ovaries are a very frequent recipient site for metastasis for cancers of other origin. For example, stomach cancer, colon cancer, breast cancer can tend to metastasize to the ovaries. The fallopian tubes are also the site of epithelial tumors. Um, and in fact, high-grade serous carcinoma is now mainly understood as being of tubal origin rather than truly of ovarian origin. Okay, so now let's start with epithelial tumors of the ovaries. Okay, they are the most common type of ovarian tumors. They account for 80 to 90% of ovarian tumors. And there are 5 main histological types. Okay, so serous ovarian tumors are composed of serous cells, just like in the fallopian tube, so cells with cilia. Mucinous tumors are composed of mucin-filled cells. Seromucinous tumors are obviously they are composed of a mixture of serous and mucinous cells. Sorry. Endometrioid tumors of the ovaries are composed of endometrioid-type glands, similar to what is seen in the endometrium. Clear cell tumors are composed of cells with clear cytoplasm, just like the clear cell tumors of the endometrium. And finally, there are transitional type tumors, also called Brenner's tumors, which are more rare. And they are composed of cells that are similar to the transitional type cells of the urothelium, hence their name. So in each of these 5 categories, the tumors can be either benign, borderline, or malignant. So we'll discuss this more in detail. Okay. Benign epithelial tumors of the ovaries. Most of them will present as a cystic ovarian lesion, and therefore they are called cystadenomas. If they also have a fibrous component to it, then the pathologist might call them cystadenofibromas, but they're all benign. The fluid within the cyst will vary according to the cell type. So mucinous cystadenomas will tend to have a very thick mucoid fluid. Serous cystadenomas will tend to have a more clear and thin fluid. Endometriotic cysts, also called endometriomas, will tend to have an hemorrhagic fluid, and if that fluid has been there for quite a while, it will become brownish and called chocolate fluid. There's so these tumors, these ovarian cysts, even though they're benign, they can become very, very large and look quite dramatic clinically, even though they are benign. There is a caveat to all of this, which is that the benign Brenner and clear cell tumors do not tend to be cystic; they tend to be more solid. They are relatively rare; they're not as frequent. But the problem with these tumors is that the fact that they are solid, they can look quite suspicious to the radiologist. Now, borderline epithelial ovarian tumor, that is a bit of a challenging concept to explain. So basically, what are they? They are a proliferative neoplastic epithelial tumor of the ovary that are not benign. They have the potential to spread, but yet they are also not understood as being truly invasive cancers. They kind of have a behavior that is intermediate between benign cysts and malignant cancers. So they have some form of malignant potential. They can spread, and they're also called tumors of low malignant potential. Patients with borderline tumors are usually young, in their 20s, 30s, 40s, so basically they are of childbearing age, and that's why fertility sparing surgery is very important for these patients. They will present with pelvic pain, bloating. Sometimes the tumor will tort, and the patient will present with an acute abdomen. Um, and also, the patients can present complaining of infertility because the tumor has replaced the normal ovarian structures. How do we diagnose borderline tumors? So they also usually present as cystic lesions, but compared to benign cysts, the borderline cystic lesions will usually show some form of proliferation, and usually that is in the form of papillary growth that can be seen either at the surface of the ovarian cyst or within the ovarian cyst. Sometimes also they can present as multilocular cyst rather than unilocular cyst. So basically like honeycomb type of cyst. Again, the caveat, borderline Brenners and clear cell tend to be more solid, but they are more rare. So the usual presentation is a cystic lesion with some evidence of proliferation, usually papillary proliferation. So these papillae can be seen on imaging, um, and therefore the diagnosis can be suspected by a radiologist, but the definitive diagnosis needs histopathological confirmation, which is examination of the ovary, which means an oophorectomy. And that is an issue because we said most of these patients are of childbearing age. Therefore, as a clinician, you might be tempted to say, why don't we just biopsy the ovarian cyst rather than remove the entire ovary in this young patient? Well, I want you to remember one thing from this lecture: never biopsy an ovarian cyst. Never biopsy an ovarian cyst. The reason is first that biopsy can be a false negative because it could, have targeted an area of the cyst that looks more benign, and then you will be falsely reassured. But most importantly is that a biopsy of the ovarian cyst can lead to um, a leak of the fluid within the cyst and a seeding into the peritoneum of the neoplastic cells if that cyst is borderline or malignant. So never biopsy an ovarian cyst. What is the prognosis of a borderline tumor? Usually the prognosis is excellent with high cure rates with surgery alone. Okay, they are tumors of low proliferation, so therefore chemotherapy doesn't really have a role in the management of these tumors. Surgery is really the way to go. Um, but we did say that they have an ability to spread to the abdomen, and therefore they can recur within the abdomen as recurrent lesions that will need further surgical excision. Okay, malignant epithelial tumors of the ovaries or carcinomas. So these tumors will tend to be more solid, less cystic, and that will make them, more concerning looking to the radiologist. Again, here there are five main histological types of ovarian carcinomas, and they will vary according to their behavior, cells of origin, and risk factors. Okay, so serous carcinomas. There is a low-grade serous carcinoma, but I will not delve into that entity during this lecture. I will mainly focus on the high-grade serous carcinomas, which are really the hallmark of ovarian carcinomas, and I will go more in detail on serous carcinoma in the next minute. The other types of ovarian carcinomas will include mucinous carcinomas. We don't really know where they originate from because technically there shouldn't be any mucinous epithelium, in a normal ovary, and we don't really know what are the risk factors that lead patients to develop these tumors. The prognosis can vary a lot. It will depend on the stage and the grade at presentation. For seromucinous endometrioid and clear cell carcinomas of the ovaries, they develop in endometriotic cysts. So basically, they represent a malignant transformation of an endometriotic cyst. They can occur sporadically, but also patients with Lynch syndromes have much more risk than the general population to develop these tumors. The behavior of seromucinous and endometrioid carcinoma will vary. It will depend on stage and grade, while clear cell carcinomas tend to be more aggressive. Okay, for transitional and Brenner malignant tumors, we think that they originate from transitional remnants within the ovary. We don't really know what leads to the development of these tumors, and because they are so rare, and we are a bit unsure about their behavior in general. Okay, so now we'll focus on high-grade serous carcinoma of the ovary. The reason is that this is the most common type of ovarian carcinoma, and it accounts for the majority of death due to ovarian carcinoma. So when we talk about the classic patient with ovarian carcinoma, usually we refer to high-grade serous carcinoma. Okay, and you notice that I call it tubo-ovarian carcinoma. The reason is that before we used to think that this carcinoma originates from the ovary, but now we understand it more as being of tubal origin. So what we discovered is that the epithelium of the fallopian tube can undergo TP53 mutations, and that can lead to malignant transformation of the epithelium of the fallopian tube into an intraepithelial carcinoma, which is called STIC, serous tubal intraepithelial carcinoma. This cancer has the ability to seed and invade and implant into the ovaries, and as well as on the peritoneum and peritoneal organs. And most of them will arise from the fimbriae of the fallopian tube. So here on the picture, the STIC lesion and cancer originates in the infundibulum of the or ampulla of the fallopian tube. But important to know that actually it's usually originates from the tubal fimbriae. Okay, very important to remember, from our neoplasia lecture where we discussed that typically carcinomas tend to first metastasize to lymph node through lymphovascular involvement. But high-grade serous ovarian cancer is an exception. It has this special pattern of spread. It has the ability to spread implanting on peritoneal surface. It does not spread to lymph node usually. Okay, and that leads to the very unusual and characteristic presentation of patients with high-grade serous ovarian cancer. So how do these patients present? Well, first, they're usually postmenopausal women, with the caveat that if a patient has a genetic predisposition to this cancer, such as she's a carrier of a germline BRCA mutation, then the cancer can develop at a younger age, and then the patient, can present premenopausal with this cancer. But usually in the general population, it presents in postmenopausal women. And the problem is that the symptoms that the patients will develop are very non-specific. So the patients will present with abdominal bloating, increased abdominal girth. Sometimes they are being told by their family doctors that they're getting fat and, be careful about what they eat. They can present with constipation, fatigue, so things that are very vague. And these symptoms, not only they are vague, but they also present at the late stage of the disease. So that leads to the fact that these patients are almost always diagnosed at an advanced stage. And when they are family investigated, the imaging will show bilateral involvement of the tubes and the ovaries, spread to the omentum, which you see here in the picture. So this is a classic example. So the serous carcinoma, when it spreads to the omentum becomes very thick, and it develops this consistency that's like a cake. And that's why it's called omental caking. The carcinoma also, we said it has a tendency to spread to the peritoneal surface, and that's called peritoneal carcinomatosis. And finally, these patients will develop malignant ascites. So that is the classic presentation of high-grade ovarian serous cancer. Bilateral tubal involvement, mental caking, peritoneal carcinomatosis, and malignant ascites. You really need to know this classic presentation. Another, not as frequent, but very interesting presentation is the Sister Mary Joseph nodule. So there was a nun that was a surgical assistant at the Mayo Clinic, and she was called Sister Mary Joseph. And she noticed that patients with ovarian cancer sometimes presented with this, complaining of this firm, palpable lump next to the umbilicus. And actually, that was a spread of the ovarian cancer into the subcutaneous tissue of the umbilicus. So the prognosis of this cancer, unfortunately, it's almost always fatal because it's almost always diagnosed at an advanced stage and it is an aggressive cancer. So the goal of the treatment for high-grade serous ovarian cancer is to prolong life of our patients and to improve as much as possible their quality of life. Important thing to know about is the CA125, which is a serum tumor marker. Okay, so the elevation of CA125 in the patient's blood is very sensitive for the diagnosis of high-grade serous carcinomas, particularly when the serum marker is very elevated, and particularly if the patient is postmenopausal. Okay, um, because CA125 is in premenopausal women is not as specific because it can be elevated due to other causes. So any irritation of the peritoneum, such as endometriosis, PIDs, benign ovarian cysts that rupture, retrograde menstruation, which are all usually phenomenon that happen in premenopausal women. But in postmenopausal women, it's very, very sensitive. CA125 can now not only be used to support the diagnosis, but also can be used to monitor response to therapy. So when patients receive chemotherapy, we follow their level of CA125, and usually if they respond well to the chemotherapy, the CA125 level will go down. Once they are done with their treatment and they're in the follow-up remission period, then they can also have a testing of their serum CA125, and a sudden elevation of CA125 can indicate an early recurrence. So it can be used also as a monitoring tool. Okay, how does high-grade serous cancer develop? TP53 gene mutation is seen in nearly 100% of these tumors. This is very important to remember. So if you remember our neoplasia lecture, TP53 is a tumor suppressor gene that regulates cell division and that prevents cells that have DNA damage to multiply and to become cancerous. So if there is a loss of normal function of TP53, then the cells with DNA damage will be allowed to multiply and progress into a cancer. And actually, it is associated with an aggressive tumor biology, also the presence of a TP53 mutation. Important to know also is that 25% of high-grade serous cancers have a BRCA gene mutation, either in the BRCA1 or BRCA2 gene. And that mutation can be either somatic, so seen in the tumor only, or it can be germline, so the patients can be a carrier of that mutation. BRCA are tumor suppressor genes, and they are crucial for homologous recombination repair, which is a process that fixes the double-strand DNA breaks. Okay. So as we just said, high-grade serous cancer can develop, sporadically, but 20% of our patients can have a hereditary predisposition. So either a family history of breast ovarian cancer without an identified BRCA mutation or other mutations, such as PIK3CA, for example, but also BRCA germline mutation carriers very well established risk factor for this type of tumor, and patients with this germline mutation will tend to develop the cancer at an earlier age. What does it look like on histology? So you will see that this cancer is also called serous papillary carcinoma. The reason is that usually it will present on histology with papillary structures, which are like finger-like structures. It is a high-grade tumor, so it will have severe atypia, so large nuclei with nucleoli. It will have a lot of mitosis. It is an aggressive, highly proliferating tumor. And very important to remember is classically, they will have what we call psammoma bodies. Psammoma bodies are round calcifications that show concentric layers of calcium. They kind of look like a bullseye. Samo in Greek means sand. Okay, so basically it's a sandy body, and the reason is that to the naked eye, it looks like grain of sand. So when actually you cut in a mental cake that has these psammoma bodies, the cake even feels gritty, as if you have sand in the cake. So even though they're classically seen, psammoma bodies are classically seen in high-grade serous ovarian cancer, they're not specific in the sense that they can be seen in any cancer that has a papillary architecture. So for example, thyroid papillary carcinoma can have psammoma bodies, papillary mesotheliomas, and others. How do we diagnose ovarian cancer in general? Very important, of course, pelvic and abdominal examination to look for an ovarian mass, to look for a Sister Mary Joseph node, to look for ascites distension. Imaging plays a crucial role, and actually transvaginal ultrasound is a very good, cheap, tool to have real-time imaging and to identify ovarian cystic lesions and solid lesions. CT scan and MRI can also be used to further characterize the ovarian lesion and to look for extra ovarian extension. We also talked about the importance of measuring the serum level of CA-125. That is mostly helpful in the high-grade serous carcinoma, but there are also other serum tumor markers. So for example, CEA and CA19-9 can be elevated in mucinous ovarian cancers, but important is that if you have a metastasis from a colon cancer, then CEA can be elevated, and if you have a metastasis from pancreas cancer, CA19-9 can be elevated. So it's not specific. If ever we're dealing with a ovarian metastasis from a breast origin, then CA15-3 can be helpful. So all these markers usually should be tested in the patients presenting with an ovarian mass. But at the end of the day, it's histopathological examination of the ovarian lesion that will make the diagnosis of ovarian carcinoma. And again, I will repeat, never biopsy an ovarian lesion. Okay, so we need to go ahead with ideally an oophorectomy. Sometimes a cystectomy can be deemed feasible and safe, and that can be an option. Another possibility is if the patient obviously presents at an advanced stage with omental caking, with peritoneal carcinomatosis, ascites, then that disease can be biopsied. That is perfectly fine. So an omental peritoneal biopsy or just a tap of the malignant ascites with cytological examination can lead to a diagnosis. Okay, so we said that for the radiologist, it can be a bit challenging to make the distinction between benign, borderline, and malignant ovarian tumors. So how do they, the radiologists, convey his level of suspicion to the clinician? So there are different tools that the radiologist can use, and you don't need to memorize these tools. You just need to be aware of what they are. So there is the ORAD system. So the ORAD system is an ultrasound risk stratification system that will help the clinicians to make, the management decisions. So it will stratify the risk of the ovarian lesion for being malignant. So ORAD1 is it's a normal ovary. ORAD2 is almost certainly benign, and up to ORAD5, which has a higher risk of being malignant, according to the radiologist's impression. Another important tool is the RMI, Risk of Malignancy Index. That is a clinical tool that the clinician can use, and that also assess the likelihood of the ovarian mass of being malignant. So that tool will combine a scoring of different features: the patient's menopausal status, the serum 125 level, and the ultrasound finding. So there is RMI 1 version and there is RMI 2 version. So in Canada, the Society of Obstetrician and Gynecologists of Canada will recommend the use of version 2, RMI 2, because it's more simple and it's more reproducible. And basically the RMI is calculated by multiplying the score from the ultrasound features by the score from being menopausal, pre or post-menopausal, multiplied by the serum CA125 level. And if the total RMI score is more than 200, then there is a high risk of malignancy in that patient with an ovarian lesion. And particularly in postmenopausal women, this RMI score has a very high specificity, and it mandates a referral to gynae oncology for management of the patient. So how will patients with ovarian cancers be managed? So the main approach is surgery. Okay. And the surgery for ovarian cancer is called cytoreductive surgery or debulking. So basically you get in there and you remove as much tumor as possible. And the more tumor that can be removed, the better the prognosis for the patient. The higher likelihood that you will live longer with a better quality of life. Chemotherapy is also a very essential tool because many of these cancers will be responsive to chemotherapy. And usually the chemotherapy that is used is platinum based, so drugs like carboplatin and taxanes, and it's a regimen that we usually call carbotaxol. So chemotherapy can be used as adjuvant tool. So you go in the patient, do a surgical debulking, and then try to kill as much of the tumor that was left behind using chemotherapy, or it can be used as a neoadjuvant tool. So if the surgeon assess that the disease that is there cannot be safely removed, then it's best to start with chemotherapy, try to shrink down as much tumor as possible, and then either monitor with radiology findings, and then maybe after 3 cycles of chemo, go into surgery and do completion debulking, and then finish chemotherapy 3 cycles additional after the surgery. Chemotherapy can also be used to treat recurrence. And nowadays there are new emerging therapies that are targeted therapies that are also increasingly used. Okay, and that leads us to discuss the role of biomarker testing, targeted therapies, and immunotherapy. Okay, so what are biomarkers? Biomarkers are biological molecules, such as genes or proteins, that are found in tumor tissue or the patient's blood, and that will indicate specific cellular changes that will predict response to a targeted therapy. So, for example, testing for BRCA mutations is essential, particularly in patients with high-grade serous ovarian cancer. So, somatic BRCA mutations can be identified in the tumor tissues, and sometimes germline mutations can be identified in the patient's blood. And the identification of the presence of BRCA mutation will open the door for treatment with adjuvant therapy such as PARP inhibitors, which is a targeted cancer therapy that will work by blocking the PARP enzyme. And the PARP enzyme plays a role in DNA repair within the cancer cells. Okay, another reason to do BRCA germline testing in these patients is that that can help identify, families with BRCA mutations, and then provide support for family members in terms of surveillance, prophylactic management, and so on. Okay, MMR testing is also important in ovarian cancer. So we discussed MMR mismatch repair gene deficiency in our neoplasia lecture, as well as in the endometrial cancer lecture. So MMR testing in ovarian cancer is particularly important for endometrioid and clear cell carcinomas. And this can be found either as a sporadic event, but it can also be due to a germline mutation in patients that have Lynch syndrome. And if we detect an MMR deficiency, that opens the door for treatment with immune checkpoint inhibitors. Okay. Anti-angiogenic drugs are also an option. So remember on the neoplasia lecture, we mentioned that tumors can develop the ability to develop their own blood supply. So angiogenic drugs will block the growth of these new blood supply to the tumor and reduce its growth. How do we prevent and screen for ovarian cancer? Well, that is very unfortunate. It is very difficult because patients, as we said, they have very vague symptoms. So it's very difficult to identify at early stage. Also, we don't have any effective screening tools for ovarian cancer in the general population because ultrasound features and CA-125 level are not as specific in the general population. They can be used in high-risk patients that are known to be BRCA carriers, but in the general population, not as useful. But very importantly, the best way to prevent ovarian cancer is not to have tubes or ovaries, if I can say so. So prophylactic bilateral salpingo-oophorectomy should be offered to very high-risk women after they're done with childbearing. So, for example, women with BRCA mutations, patients with very strong family history, or patients with Lynch syndrome, also that have increased risk of ovarian cancer. Okay, so we will take a pause here and we will come back in the second part of this lecture and discuss other types of ovarian cancers.